Welcome, everyone. The title of our presentation today is Planning and Developing a Culturally Safe Framework for Engaging Immigrant, Refugee, Ethnocultural Patients in Mental Health Research. And we're pleased to have support from Michael Smith, Health Research BC, BC Support Unit, and the University of Victoria. In our presentation, I would like to acknowledge with respect that we are sitting on the Algonquin people's traditional territory on which the University of Victoria stands, the Songhees, Esquimalt, Wasanich people whose historical relationship continues with us to this day. I would like to acknowledge our research team. My name is Nancy Clark. I'm an assistant professor at the University of Victoria in nursing. I'd also like to acknowledge Anita David, our patient partner and researcher with SPARC, Mental Health Commission of Canada, and BC Mental Health Substance Use Services, community-based research, and trainer with the Canadian Mental Health Association. Dr. Kathy Costigan is a professor in the Department of Psychology and a fellow with the Center for Youth and Society at the University of Victoria. Dr. Fred Chow is also an assistant professor in educational psychology, leadership studies at UVic. And Cindy Kwan is our research associate and clinical specialty in psychology. She is a PhD candidate at the University of Victoria. So just by way of introduction, we wanted to provide a bit of a background. So the choice to use immigrant, refugee, ethnocultural, racialized category for our patient group is based on the Mental Health Commission's report on systemic barriers to mental health care services and poor health outcomes for this group. In particular, the relationship between race or visible minority status and mental health outcomes, which are not well documented in Canada. What is a common challenge, however, is that mental health systems in high-income countries have increased rates of mental illness, poor access to care, and reduced care outcomes and satisfaction with services, which have been reported internationally. Second, Canada's strategy for patient-oriented research is for patients, researchers, healthcare partners to actively collaborate and build on sustainable and equitable health systems to bring positive changes in health of people living in Canada. So since patients are at the heart of strategies for patient-oriented research, they must be involved as meaningfully as possible to be included in research. So patient-oriented research is done in partnership, but our experience suggests that there's been a lack of inclusion and partnership developed with mental health patients who also come from diverse backgrounds in strategies for patient-oriented research. Cultural safety is a lens that we applied to understand how we can meaningfully engage our patient partners and diversity issues in research. So typically, cultural safety as a concept has been applied with Indigenous patients accessing healthcare systems, but less applied with immigrant and refugee communities. Moreover, it hasn't been explored for its utility as an approach in strategies for patient-oriented research, and thus cultural implications are less known. So our purpose was to plan and develop a project to build capacity with immigrant, refugee, racialized patients to explore how cultural safety could inform potential strategies moving forward in mental health research. And just to note that the term is quite complex, and it does really resonate with patient-oriented processes. It was originally termed by a Maori nurse scholar, Dr. Ramsden, in the New Zealand context and the Maori context of colonization. Core concepts of cultural safety include partnership, participation, protection, recognition, respect, and power. And essentially, they're any actions which diminish, demean, or disempower the cultural identity and well-being of an individual, and that involve actions which recognize, respect, and nurture the unique identity of the Tangata Whenui, and safety that meets their needs and expectations on rights. So it was very much rooted in a Maori context but we're applying it here to look at diversity issues related to patient-oriented research. So just to begin, we began our culturally safe patient-oriented process by recruitment of immigrant, refugee, ethnocultural, and racialized communities. And that recruitment consisted of word of mouth through third-party recruitment, Patient Voices Network, through Reach BC, the Adult Mental Health Substance Use Services on Vancouver Island, as well as Vancouver Island Counseling Center for Immigrants and Refugees, otherwise known as VICR. And we also included patient partners, and we had a process of engagement, and we did a concurrent literature review to also inform how we should develop strategies. And I'll allow Anita David now to walk us through who our patient partners were and what that process looked for us.
Thank you, Nancy. So I worked with the researchers to provide support and also knowledge exchange as a patient partner consultant during all team meetings and patient partner meetings as well. I was also involved in screening the patient partners to not only discuss their involvement in the project, but also to make sure that they understood their role would involve them sharing their own experiences, which I call emotional labor. It was important to ensure their understanding of their role on the project and make sure they were in a good place of their mental health journey to be able to contribute. Once recruitment was done, we had 5 patient partners, which included first and second generation immigrants. The partners varied in age from 23 to 54. Partners were self-reported on their cultural backgrounds to be Iranian, Chinese, German, and mixed heritage of Caucasian and East Asian. Patient partners also included varied genders, included non-binary. All experienced racialization and stigma related to lived or living experience of mental illness. Given issues in accessing healthcare and stigma related to the mental health patient group members with lived and living experience of mental health issues, some didn't want to be identified as mental health patients. Others felt that that was not reflective of their experiences. And other terms that came up were service user or community member. A key part of my role was to facilitate the relationship building and engagement with the members of the research team. I also collaborated with Taylor Haynes Stock at Island Health through the BC Support Unit to create a patient-oriented research session for all members of the team. The purpose of this was twofold. It was to build the capacity of all team members in patient-oriented research, and it was also meant to be a team building exercise so that we were all learning and collaborating and learning together, sharing. There was pieces of the session where people could share their experiences and just build those building blocks for communication. And that served us as we moved forward in the process of over a year, where we had meetings with our patient partners, which I'm going to use that term for this. So patient partners, where we engaged in deliberative dialogues about cultural safety and patient perspectives and experiences. These conversations happened during COVID, so they were held over Zoom and patients were compensated for their time. Thank you.
Thanks, Anita, for sharing that process with us. And now Cindy is going to walk us through the literature that we did concurrently just to analyze what is known about this topic.
We conducted a scoping review as part of the patient-oriented research planning and development grant to understand what constitutes cultural safety when conducting research with immigrants, refugees, and racialized people with lived experience of mental health challenges. To do so, we used Arxiom O'Malley's scoping review methodology with Levax and Knowles and Joanna Briggs Institute's recommendations for evidence synthesis to examine the extent, range, and nature of research around cultural safety when working with this population. The methodology includes 6 steps. So first, we identified the research question around what constitutes cultural safety when engaging in mental health research and policy with IRER populations. We then identified the relevant studies by consulting with the subject librarian with expertise in systematic reviews to develop the search strategy for empirical literature as well as our gray literature. Our empirical literature search included PsycInfo, CINAHL, social services and sociological abstracts, as well as Medline. And the period for the search strategy was from January 1st, 2000 to April 1st, 2021. The study selection was done based on including immigrant refugees or racialized people, so the population of interest, the concept around elements of cultural safety, and the context around mental health research as defined by the World Health Organization. If we go to the next slide, you'll see that we have included a diagram for the study selection and the study inclusion. On the left hand, you'll see the identification and selection and screening process for the empirical literature that was all screened by both Nancy Clark and I through an iterative screening process. And on the right-hand side, you'll see the screening of the gray literature, which included both databases of theses and dissertations, targeted website searches, and search engines based on conversations we've had with the research team. Finally, following the standards for scoping review, we did not assess studies for methodological quality, but we started coding what was in the relevant literature of interest. So here is a excerpt of some of the ways that we went about this. We first looked at each articles after the screening process was complete to look for elements related to cultural safety that met our PCC criteria around population, concept, and context. And these were then coded and summarized. We then combined and renamed codes as themes aligned with the concepts that fit the research question. Our research team including the consultants that met to discuss the preliminary themes that we had around partnership, transparent practices and procedures, respect for cultural humility, reciprocity, feedback and evaluation, and power. And patient partners confirmed that these themes identified in the literature were important elements of cultural safety and provided additional ideas to include for the guidelines. You'll see here that we counted the frequency in which we saw these strategies emerge as part of the empirical literature, the gray lit, and the most common ones are represented on the left-hand side, and the least common ones on the right-hand side. And Nancy will describe each of these themes in more detail.
Thanks, Cindy. Yeah, so as we can see that there were elements of the principles of cultural safety embedded in the literature. For example, partnership and having good partnerships with stakeholders and advisory boards, for example, immigrant settlement organizations or even faith-based communities could provide more of a safety measure, if you will, so that trust could be developed with patients in the community or community members. And then it was also very important to have transparent practices. In other words, being very clear about what patient partner expectations are and what the expectations of the researcher are. We found that the patient groups and the researchers identified that being reflexive of different cultural identities in terms of language and cultural norms was also important in the process of conducting research with these patient partner groups. Reciprocity was about co-learning and creating an environment where that could actually happen. So having space and time to do that with communities and patient partner groups. So in other words, knowledge was co-constructed, and it doesn't only come from extracting knowledge from the community, from the researcher. Clear finding was that there was a gap in terms of feedback and asking patient partner groups what their experience has been in engaging in research processes. And the least common was attention to power, which is an interesting finding because the crux of cultural safety is attention to power and mitigating power inequities based on our social differences. So this was the least common theme, if you will, that was described in the literature. In our discussions with our patient partner groups, they clearly identified that there's a need for strategies for patient-oriented research to have an ethical mandate. In other words, a social responsibility to the communities and patients that are engaging in research, but also to attend to the emotional labor that Anita had mentioned and psychological safety, being flexible and understanding of the unique needs of patients that might be experiencing illness or wellness within those trajectories. So in our discussion, we looked at how immigrant, refugee, and racialized patient groups require increased support and collaboration for partnership and engagement. There is definitely a need for more time and opportunity to engage these patient groups to tell their stories and to share their experiences. So again, having the space and time to do that. And Anita's just going to touch on the second points, and then we'll conclude with Cindy. Yeah, so in our discussion with our patient partner groups, we really saw that there was a congruence between the empirical literature and what our patient partners were telling us, that there needs to be more collaborative partnership and engagement. There also needs to be more time and opportunity for patients to tell their story and share their experiences. So in other words, we need to plan for having more space and time within research in our strategy. And that researchers tended to describe cultural safe strategies when working with these mental health patients around partnership, transparency, respect, and reciprocity. However, issues of feedback and actually asking what the process was, attention to those power relations, the social responsibility and psychological safety was less explored, which was interesting because we only looked at mental health research literature. And finally, to our point, in collaboration with our research team and our patient partners, we would like to think and invite you to think about what strategies for cultural safety do you currently use, and if any of these strategies could be beneficial as you see yourself moving in more toward issues of diversity in patient-oriented research. So which one of these strategies could you see yourself trying to incorporate more? And thank you very much for your time and interest today.